We have Dr. Sam Cytryn from Memorial Sloan Kettering Cancer Center. We have Dr. Shikha Jain from who does hematology oncology and many, many other things at University of Illinois Cancer Center. Amazing Women in Medicine Conference. Thank you for that last year. And then we have Suneel Kamath, GI oncologist at the Cleveland Clinic. And we have, Dr. Suneel, and Dr. Nataliya Uboha, who is a GI medical oncologist and associate professor at the University of Wisconsin. So I think we're just gonna go right into it. With that said, let's first talk about something that is in the press a lot, and that's colorectal cancer. You've all heard about, the age difference and how it can be slippery, have really good responses here, otherwise not here. I got a lot of DMs about the miracle drug, but obviously there are parameters on when these kind of things work. Talking about atomic, adjuvant atezolizumab, so immunotherapy with chemotherapy in a stage 3 MMR deficient. So when we're talking about the asterisks on something that may, make something sensitive to certain treatment, not exactly targeted therapy, but still a prognostic score. How do we feel and what is the excitement and does it persist for these cancer types that are MMR deficient when they receive immunotherapy after, which is not a common thing. Well, it's common in stage 3s and later 2s, but when we were talking about lung, we're talking about neoadjuvant and adjuvant a lot. We don't do neoadjuvant as much as colorectal. How do we feel about using immunotherapy in stage 3 colon with this?
So I can start. I think, I always joke that whenever I come to ASCO, I love being a GI oncologist, and then I come here, I get really sad because people do standing ovations for like breast cancer, and GI onc doesn't get the love. But we've often talked about the fact that when it comes to adjuvant therapy in the colon cancer space, we don't really do immunotherapies in the colon cancer space when it comes to adjuvant. There was the IDEA trial that looked at the length of how much adjuvant chemo to get, of 3 months versus 6 months, and it was found that, hey, we don't actually need to give 6 months of adjuvant therapy. So that was very exciting, but there hasn't been as much really exciting data about adding any therapies like atezolizumab. So I thought this was really interesting, and the fact that we're seeing benefits adding on atezo in the adjuvant setting, I think it is potentially practice changing. I think it's really exciting to see that we can incorporate these kind of more novel agents, incorporate not just chemotherapy. The one thing I want to comment on, and then I will pass the baton to someone else, is I believe, and correct me if I'm wrong, I think they looked at 6 months of FOLFOX therapy in this case, which I think is interesting because most of us really do 3 months of adjuvant therapy now, even in the MMR deficient patients, because of that IDEA trial that showed there wasn't an overall survival benefit, 6 months versus 3 months of chemo, other than very, very tiny population. So I would be interested to see what my co-panelists think about that and the fact that they gave 6 months of chemo along with the tezo. But I do think someday we're going to see standing ovations for GI oncology at ASCO because we're starting to see this type of innovative combination therapy, not only in the metastatic setting, but also in the adjuvant setting.
I agree. I actually have a patient with MSI high colon cancer. She right now has stage 3 colon cancer and I am giving this patient adjuvant FOLFOX, and it's painful. We've been waiting to have a reason to give immunotherapy in adjuvant setting because we know how well it works in neoadjuvant setting. We know the activity in metastatic disease, and yet in adjuvant setting, we give chemotherapy. That being said, it's rare to see these tumors. It's amazing the study was even conducted. Most of the MSI high colon cancer that are in my practice actually stage 2s, and these patients do not get anything in adjuvant setting. Stage 3s are tough because we know that 5-FU alone doesn't work, so you're committing patients to combination chemotherapy, which is toxic. I absolutely agree. 3 months is most often something that we give, and even when we plan to give 6, most patients cannot tolerate 6 months of oxaliplatin because of neurotoxicity. I think the discussion was excellent today, really questioning how much chemotherapy we actually need, and the study under ideal circumstances would have had a third arm, atezo alone, but the study was designed when it was the appropriate design for the time it was launched. And so, but that remains a question. Can we actually omit chemo all alone? I hope with the ctDNA and other studies will help us determine that.
Yeah, I want to highlight, I echo what you said about Dr. Chalabi's discussion. I think she did a wonderful job. And to put it in the context, this is one of the instances where I think overall we would favor neoadjuvant therapy. It's certainly useful for patients who are symptomatic, undergo upfront surgery to now have access to a PD-1, PD-L1 inhibitor. But it goes to the importance of biomarker testing up front before making these decisions in a multidisciplinary fashion so that before they go up undergo upfront resection. If you know the MMR status and they are mismatch repair deficient, at least I, and I think many of us, and as we were talking about before, would favor neoadjuvant checkpoint blockade rather than resection.
And I just want to add one thing to that, because you both mentioned something in the neoadjuvant setting along with ctDNA. I think that we're going to start seeing more and more if we can incorporate these types of agents in the neoadjuvant setting, and then we can use ctDNA as another data point to determine how long does the patient need treatment? In rectal cancer, we now have patients who don't even need surgery eventually. So are we heading towards, can we get to a point for, again, very select patient population, but can we get to a point where we can give them neoadjuvant immunotherapy and we can avoid the toxicities of chemo, avoid the neuropathies, and potentially in the future, maybe even avoid surgery, which for any of you who's taken care of a colon cancer patient, can be very traumatic with an ostomy and all the complications that come with that. So my hope is that we also start to see ctDNA incorporated into some of these trials so that we can hopefully minimize the amount of therapy we're needing to give these patients.
It might be a silly question, but help me understand, a lot of, at least in the community setting, when you're staging, especially getting a stage 3, you're looking at the lymph node status, it's post-resection, you're looking at the depth of invasion. Even the education piece, say this is what you want to do, like how exactly are you assessing that high number of nodes that you're supposed to look at and do all of those things in a setting to where you're trying not to resect it, which a lot of them you do post-resection to then send them back to the med-onc. Like how does that look?
Yeah, I would add that's extremely messy, and I think it's a really important part of this issue for the non-operative management question, which I hope we can get there, but I think our radiology colleagues really need to catch up to this technology in a way, because
Radiologists.
I think Dr. Sinico made a great comment that the nodes are often enlarged for these cases, and they're usually negative.
With inflammation and
Due to the inflammatory state of the tumor, the primary tumors are usually very large and bulky, but you've had times where it looks like a clear T4B and it turns out to be a T3 instead, and it's just a lot of inflammatory milieu around the tumor. And so definitely I think we need a lot of help as far as the initial clinical staging radiographically before I think we can really apply a good non-operative management paradigm here.
I think the reality is that in the community, these patients come to see medical oncology after resection.
Right.
And so it's really tricky to capture these patients, especially colon cancer, where multi-D neoadjuvant care is not required early on. So I think it's going to take some time for the education, and if the practice were to change, because the current standard practice is still upfront resection, but it will take some time.
No doubt. And on that, on keeping in colorectal, I'd love to kind of briefly discuss breakwater and specifically the progression-free survival and the overall survival update for first-line encorafenib plus cetuximab plus modified FOLFOX6 in BRAF, which we know, BRAF V600E mutant metastatic colorectal cancer, which we know is a pretty stubborn and scary disease type to begin with. So is it something that excites you all? And if so, what is that?
Yeah, I mean, this was probably one of the things that really stood out the most to me at this meeting. With the, we've had the Beacon regimen, second line, the Encosatux for quite some time, but it was a very, very modest survival improvement in the second line setting. And so, we were always wondering, would there be a synergy when you bring it with chemo up front? And there was a synergy and then some, I would say. I mean, to see a median OS of 30 months versus 15 in the control arm is unheard of, I would say, really in CRC in general, let alone for a BRAF mutated disease. So I think, 30 months median OS is nearing really what you see with non-BRAF mutated colorectal cancer, and that's really a huge win.
And I want to add, when it comes to something that you brought up earlier, was communicating with patients. And so I was talking to some people and they said, oh yeah, it doubled the overall survival. And I said, that's great when you're talking to us. But if you're talking to a patient and you say doubled overall survival, they're going to say, what the heck does that mean? So I think I really appreciate the fact that you brought up it's 15 versus 30 months. I mean, that is a huge, for cancer patients, for BRAF mutated cancer patient, colon cancer patients, that is a significant change in overall survival. So if you are communicating this to patients, don't say it's a doubling overall survival, because they're not going to understand how impactful this is.
Yeah, and you're right. It really was impactful. But the 4-drug regimen is toxic, and I think there are patients who are perhaps too frail to get it. So I think one of the things that this study did really nicely is it had each of those 3 arms, where it had FOLFOX alone, the standard of care, but then it had the Encosatux alone or in the absence of chemotherapy, and then the combination. And so while certainly the combination of all four perform the best, and that's what I would give a fit patient, in a elderly, more frail person, you can still have the option for the targeted therapy, which had a numeric improvement. And I think it was a nice sort of corollary part to the discussion.
I have nothing to add except for biomarker testing is
100%.
key. Biomarkers. We don't get BRAF testing quickly based on tissue testing, NGS tissue testing. So liquid testing, NGS testing is appropriate.
So I have a question on that actually. So in the past, right, traditionally, NGS testing was covered for metastatic disease. A lot of docs in the community don't often order it for stage 1, 2, or 3. But in academics, I think we often do. So I'm curious, what are those conversations? How do we have those conversations? Because I know what I say. I usually tell people we need to get this testing, not only because it helps in the upfront setting with what we're seeing with trials, but also if this patient becomes metastatic, you want to know their mutational status. But I've gotten pushback from community docs who say insurance doesn't always cover it. So how do we navigate that?
Well, at least in metastatic setting for BRAF testing, I think it's pretty straightforward and it's usually covered. In stage 3, I have to say I don't usually have these conversations with community about testing in stage 3 disease, although there is data coming out about the presence of PI3 kinase mutation in aspirin, so you could start justify that you even need to test earlier. I do test my patients, high-risk patients across disease types in stage 3 setting and with these extensive molecular testing platforms, and I've not had pushback, but I'm sure it's different across different parts of the country.
And I think it's really important to focus on what question are you trying to answer. Is it molecular profiling, or is it, molecular residual disease, minimal residual disease? Because if it's the former, there are comprehensive blood-based NGS tests that don't require insurance that are covered, and it's a one-time thing that comes back faster, and you have your biomarker analysis then, and you're not following it serially necessarily. If it's a minimal residual disease test, Signatera among others, it's a bit more murky.
Excellent. These are all very, I think the mutational status, biomarkers, understanding tumor behavior, prognostics, the what's, the whys, is so important. Moving a little higher up the track, if we could talk about upper GI, the Matterhorn study was looking at the event-free survival phase 3 now data on durva plus FLOT for resectable GI or GE junction cancer. One of the things on AI discussions that people talk about is perpetuating bias. And it's not always bias when it comes to what is out there with racial and inequity gaps, et cetera. But sometimes even the physician's bias on regimens that were either really toxic and you had an atypical, bad toxicity, or you just don't have good luck. And for me personally, FLOT, we pushed through, and my wife actually as well, we both have not had the best, or at least what the data shows, responses when it comes to actually getting even to resection for that matter. Is this something that it's just one of those things, right, to where you'd want to remove yourself of that? So what did we see when we looked at event-free survival when you're able to add durva? And is this something that excites you?
This was a practice-changing study. Perioperative FLOT chemotherapy has been the standard. I'm sorry, your family has had trouble with delivering FLOT. We can talk offline about the dose modifications that you utilize. It is a tough regimen.
We got through it. It just didn't work that well.
Oh, it didn't work.
Yeah,
that's bad. That durva, nothing is going to help. There are some patients. I have to say it's pretty active. Like patients who respond, it's amazing because in Midwest, at least, I see a lot of GE junction tumors. Patients with GE junction tumors and patients have a lot of dysphagia, and so really after 1 to 2 doses, patients are able to swallow easier. So it is pretty active. When it doesn't work, it's bad news. That's a very chemorefractory disease. But this Matterhorn was a global study that asked the question whether durva can improve EFS, basically survival outcomes, with the addition to chemotherapy in perioperative setting was positive. Definitely exciting. Are we curing everybody? No, but are we really moving the needle in the right direction? Yes, and it doesn't add much toxicity. It does not. What was, and it's been shown already. Some of the data has been shown at ESMO before. It didn't compromise patients' ability to get to surgery. Yes, it's hard to give FLOT after surgery. We've known that already, durva or not, so it doesn't compromise that. But we are seeing longer event-free survival, and I think the survival curve hopefully will continue to separate. The data is still not mature, but I'm excited.
Yeah, this is without a doubt the most exciting abstract presentation, that has been at this
From
conference.
Sloan Kettering.
Yeah, I'm
so,
a little
biased.
He's not biased at all.
I'm a little biased.
This is no doubt the most exciting.
But I think this study, I think there are a number of things that the number of countries that were a part of this study. You speak about how difficult FLOT can be. There were patients who were 80, in their 80s on this study. It is the cure rates are moving up. And last year we saw ESOPEC and it was an improvement on CROSS, and this year it's this. Who knows what we'll see next year? But maybe that's a little bit ambitious to be that quick. But I think this is practice changing. The one comment I would make specifically about the OS is it says it on the slides. The interim OS p-value was 0.001, so it did not meet that threshold. But if you look at the final OS p-value, it's 0.049, and so it has already met that. It has, and you, not to be too grim about it, but if people pass away, they're not coming back to life. So it is all but a certainty in my mind, from what you can, as best you can predict, that this will hit OS.
AstraZeneca just wanted to have 2 plenary presentations, so
Yeah.
maybe we'll share the OS.
Well, and
Stats backed it up.
And I'll add, so this study was not obviously a primer on whether FLOT is good or bad, right? Like, we know FLOT is toxic, we know FLOT is hard. The one thing, and I cannot be on a panel like this and not mention this because we're talking about clinical trials, I like the fact this is a global study because, again, it's a very heterogeneous population. I'm a GI oncologist at the University of Illinois Cancer Center. 80% of our patients are from the Black and brown communities, and they are not represented in 100% of the trials that we see. Everybody we talk to, the trials show like less than 5% of our patient population is represented. So the fact that, one, this is a global trial, I think that's really powerful because it shows a very heterogeneous population. I think FLOT sucks in general when it comes to toxicities, to be perfectly frank. So again, this isn't a primer on FLOT. This is FLOT plus Durva, non-inferior or better. And with the event-free survival, I think that it's obvious that Durva is going to become a part of what we do. And again, dose reducing for toxicities and things like that, that's not going to change whether you've got the Durva or not. So I do think it was a powerful study, but I have to put in the plug that if any of you do clinical trials, we really need to be, one, thinking about where these trials are being done, two, who are the patient populations that we are serving, and three, is it a heterogeneous enough population where we're not just seeing one slice of our nation represented or of the world represented in the trial. So I really appreciate the fact that this is a global trial that does showcase the fact that it's not just one group of people that benefits.
Yeah, I think it's so important, especially that it was about, I think, 20% or less from Asia. I think that's often an issue at times with these trials, that they're predominantly enrolled in Asia. And we're always left wondering, for a mostly Western European population here, does that really apply or not? So I definitely think that was a big strength for sure. I would also add, I'm sure we will with this start to give, the 6 to 8 cycles of FLOT pre-op along with the Durva. I think as many of us do.
D-FLOT.
D-FLOT now, yes. I know, I'm really glad Sam gave us a name. I didn't know, would we go D-FLOT or FLOT D? No, D-FLOT sounds much better, yeah. So, but yeah, I definitely think, we tend to give a lot of it totally pre-operatively. It's very difficult to give
I don't
FLOT
do
in
that.
general. You don't? I find it very difficult to give any
Y'all can meet in the parking lot later.
I don't want to be included in the B part.
I don't do it either. I don't give 6 to 8 cycles either.
I do 4.
Yeah. Same.
I mean, one of the things that's important that I think doesn't get talked about enough is the moral injury that also contributes to burnout. And when I tell you, you go into this patient review, like, we're doing it for a reason, it's the best thing, it should shrink. You're mortified to go in that room and tell them that all of this sickness, and you find out that tumor didn't shrink, it increased, or that they had to go in and abort it because you couldn't even tell. You're like, I think it shrunk. There's no lymph nodes on the outside. And my first 2, they had to just abort the surgery. And then I'm embarrassed, right? Like, I feel terrible and ashamed, even though we got through the FLOT. So you can imagine what what these kind of things also kind of help in that capacity.
Can I just say, I expect next year there to be a rap song presented at ASCO, D-FLOT.
D-FLOT, there we go.
Just throwing it out there.
Taylor Swift will actually sing that
There
song.
we go. Perfect. That would be perfect, honestly.
So moving on, but staying in the upper GI, Checkmate 577, the overall survival results for adjuvant nivolumab in resected esophageal or gastroesophageal cancer following neoadjuvant radiation concurrently. How do y'all feel about it? Is it exciting? Immediately practice changing?
You know, there's some pieces of information we're missing from that study, and it's really this separating the survival curve by histology. I don't think it was disappointing to see overall survival result not being positive. I think improvement of EFS of 16 months is still clinically significant. I do not think it will impact my practice much because distal esophageal, GE junction, proximal gastric is the same disease. And so these patients are treated with perioperative chemotherapy. True esophageal, mid-esophageal adenocarcinoma doesn't really exist, or maybe once somewhere. So, you know, these patients do not get preoperative chemoradiation. And so the patients who will get preoperative chemoradiation will be patients with esophageal squamous cell cancer. And I suspect that the patients that also, once we see more data, the ones that probably derive the most benefit from adjuvant immunotherapy. Am I going to give those patients adjuvant nivolumab? Yes. If they have residual pathological disease at the time of resection, but adenocarcinoma patients will receive perioperative DFLOT.
Completely agree that, right, for adenocarcinoma, it's this is not so applicable, and for squamous cell, I'll continue to give it. The one thing that I don't think came up, and I don't think there was a manuscript for this, so I'm curious to look back at it. The OS was statistically not significant. And on the placebo group, I think only 15% of patients got, for when they recurred, got immunotherapy, which is now standard of care. And I understand this was began enrollment 8 years ago, and so it's not necessarily a comment on the doctors taking care of those patients, just whether or not it was approved. But one could imagine that if this was done now, then the question it's really answering is it curing more people? Is immunotherapy now or later better? And if it was not significant with a small minority of patients getting checkpoint inhibition, it would stand to reason it's going to be even less significant when more people get it. So,
global study probably reflective of different practice patterns.
That's right.
However, I still think that having patients, this disease is debilitating. When patients develop recurrences, this is terrible, whether local recurrences, distant recurrences. So having somebody for 16 months free and maybe probably longer for squamous once we see the data, I'm hoping, because the EFS, it's DFS in that study for squamous much longer when the initial data was presented, is clinically relevant.
I don't have much to add other than I always get excited that we're seeing more and more immunotherapy being added in the neoadjuvant adjuvant setting. Because when I trained and for the first couple of years of my career, that was not what we were seeing. So I don't think it's practice changing now. I think that it is something that we definitely are going to continue to see evolve. But it's exciting to see these studies coming out.
Yeah, I was relieved to see the data because it took so long to come out. It always makes me wonder did the OS turn out to be completely negative, or was there a reversal of the DFS or something when studies read out this late? So at least it was confirmatory of what the original findings were. So I think, I agree, squamous, it makes sense. I do wonder about, if you're PD-L1 positive and not eligible for flat, there will be a few like that. So I would consider it in that setting too. But yeah, I wouldn't be super happy with it. But you could do what you have to do, I guess.
All right, moving on to pancreatic. PANOVA-3, we were thinking about a discussion around gemcitabine and nab-pac for locally advanced pancreatic PDAC, pancreatic ductal adenocarcinoma. What do y'all think, and how do you feel about what they found? I mean,
so with the addition of the tumor treating fields, it was an improvement. I guess, my question is, for a patient in whom I would otherwise give gemcitabine and nab-paclitaxel, it's a consideration. To be honest, it's something I have to learn more about because I have no personal experience in treating patients with this therapy. But I don't see that it would necessarily change what I would consider doing in a patient who is fit enough to receive FOLFIRINOX. I'm curious.
Yeah, I wonder about, the device, it's a big array. You wear, front, back, the sides. You have to wear it for at least 16 to 18 hours a day. So that's a big, quality of life. Even though, the toxicities, the AEs are not particularly that harsh, but it's a major quality of life change. to carry that around. It was a 2-month survival benefit, so certainly meaningful in this disease. But I wonder about if you did SBRT or IRE or a number of the other sort of local interventions we can do for pancreatic tumors. Might we have seen the same results without having to have someone wear something consistently on an ongoing basis?
Well, and I'd be curious what you mentioned, seeing if there was a comparison between this and FOLFIRINOX, right? Is there a benefit? Because the one thing that they mentioned or the two things they mentioned, one is there's that little, OS benefit, but then there's also the pain. It sounded like quality of life was also improved. So we know FOLFIRINOX we usually only give to our very fit patients, and Gem/Abraxane usually is for patients who aren't necessarily as fit often or can't get the potential toxicities of FOLFIRINOX. So I think it would be interesting to see, one, is there any real benefit if you do this Gem/Abraxane plus the TTF, thank you. TTF, if you do that combination versus FOLFIRINOX. The second thing that I think is really, again, I always am thinking about my particular patient population is access and who would actually have access to this type of therapy, whether it'll be available globally in the United States or not, rural areas, patients who are construction workers, the having it around your body for extended periods of time. Is it something that's practical for somebody who is working and functioning and doing all those other things? So, but I do think it's interesting. I think that more trials would be interesting to see if FOLFIRINOX would have a big difference. And if not, then I don't think I would switch from my patients who have a good ECOG status. I would probably still do FOLFIRINOX first.
I think a lot of medical oncologists are trying to wrap up a mind about why would a device make people with pancreas cancer live longer? Because we all think about this as being systemic disease and micrometastases, and we all just so excited to get a KRAS inhibitor improved, right? But yet, it's a phase 3 study with positive OS outcome, right? Those don't come often, right? Once a decade in pancreas cancer. So it's hard to ignore, right? But I think we're also trying to figure out what we're going to do with this now, right? Yeah. That's what you're hearing. Yeah. We're not denying the data. We just don't know what's going to happen.
Right. Well, it was on the cover of the ASCO Daily newspaper today, and I don't think I've seen pancreatic on the front of the ASCO Daily paper.
Unless it's bad.
So that, yeah, exactly. It doesn't happen. So, I agree. The overall survival benefit is definitely a real thing, but I think practicality, how would we actually deliver this care, and what are we going to do with it is the biggest issue.
Yeah, we're going to have to befriend our neuro-onc colleagues very soon, I think, to get this. Hopefully they're used to it.
You don't have any radiology friends anymore.
Sorry, guys.
And lastly, the CASSANDRA. So neoadjuvant PAX-G versus modified FOLFIRINOX for resectable, borderline resectable pancreatic adenocarcinoma. What are your thoughts?
Flood is a nothing now. Now we have 4 chemo drugs at the same time. I thought it was very positive, and amazingly, the tolerance seems like it was okay. I'm not ready to start using it just yet in my clinic. I honestly need to think about it, even though I was on that podium listening to all of this. But I was surprised about the results, positive study.
Yeah, I agree. I think it needs a little more contemplation from me as well. I think the other thing, and part of the question is, if you're running through all of your options, 4 out of your 5 best therapies, or not, best is a very low bar in this situation, but if you're running through all 4 of them right up front, does that, because this was an improvement in PFS, not OS, so.
I have to say, I struggle with thinking about it that way in patients who have curative disease, potentially curative disease, because I don't want to save anything till later, because if there's a chance.
Yeah, that one shot.
Yeah, one
I
shot.
agree.
But I hear you.
Pancreas especially, yeah.
There's KRAS inhibitors coming. I'm at Revolution Medicine people over there.
Well, and I also think the age of the patient matters, right? If you're looking at somebody who's 45 versus somebody who's 75, you want to throw as much as you can at them if you're going to give them the chance of cure. But again, I understand it's the whole concept of sequential therapy in colon cancer, right? Giving irinotecan and oxali and 5-FU upfront in colon cancer patients if you're trying to convert them to a curative intent. So I think again, it's going to depend. It's patient based, but I understand the fear or the concern or the apprehension of not wanting to give everything up front. But again, if they're going towards curative intent, then do you want to give them the best chance of that, hopefully?
It was very surprising, too, that it was more drugs, more effective, which that I expect, but actually tolerability was better with PAX-G than FOLFIRINOX, too, which I found very surprising. The dosing of PAX-G is not light, was 1250 of capecitabine, 150 of Abraxane. It's legit chemo. But surprisingly, even the toxicity profile was better as well. So, yeah, we'll have to see. I know the follow-up is planned, and we'll see if it pans out. Because otherwise, I think we would start doing it.
Yeah, it's that borderline, that one-shot concept that I know you still have some more to say on or thought about. But like it was kind of like how Stephen said earlier about adding lurbinectid into to Atezo in the maintenance line of small cell. He said what really matters though is how long before you were going to use lurbinectin in a topo anyway, which is about 6 weeks later, and that was in a stage 4 setting. So pancreatic obviously is one that the tolerance or the ability to use multiple lines is already pretty challenging, and then also how quickly the recurrence occurs.
Well, I also think pancreatic's different now than it was 15 years ago, where we're seeing more and more younger and younger patients. And so I think the population we're treating in a lot of these cancers is very different. So when we're looking at toxicity profile, when we're talking about overall survival, we're talking about somebody who is 40 and might potentially have another 30 years to live, as opposed to somebody who's 85 and probably doesn't have 30 years to live with or without cancer. I think there's also a way we're, as oncologists and GI oncologists, thinking about our patient's age and their performance status, but really when we're seeing these young patients, what can we do to potentially get them to cure?
And to that point, why I say, that's one thing AI will never be able to do. Doctors will always be around because it's those kind of considerations that are truly just important. The metric of suffering as a value and salvage. So I was specifically told that if it's a vibe with the panel, that we can keep it going a little bit longer than time and do some questions. And I consider this a full vibe, but hopefully y'all agree. So does anybody have any questions that you're pressing that you want to hear? Yeah.
So all of you mentioned using 3 versus 6 months for the most part of chemotherapy. And when you use 3 months, are you always using Capox? And what is your experience in terms of tolerance? Because as you pointed out earlier, one really bad experience burns you for life. And I had a woman with, I think she was stage 2 high risk, and she got really, really sick, ended up in the hospital, aspirated after vomiting, and died. And I've had people weeks in the hospital with Capox. So are you seeing better tolerance these days?
So I will say that I actually started using a lot more Capox during the pandemic. Before that, I was a full Fox stan. Like I did full Fox for almost everybody. But I started using more Capox during the pandemic because 1, it was less clinic visits for patients. 2, they didn't have to come and drop off the pump. 3, they liked the fact they were getting a pill. I used to think that CAPE gave way more toxicity for my patient population than 5FU. But I think now what I'm realizing, I'm starting prophylactically to think from the very beginning. You start CAPE, you get the lotions for your hands, whether it's urea cream or Utterly Smooth or whatever the lotions are that you're using. I think making sure that you have that constant communication. I'm very fortunate. I have a nurse practitioner and a team. So I tell my patients, if you're having side effects, I need to know as soon as you have them. So we can start, duloxetine if we need to. We can start those agents very early on. That has been really impactful. And I think it really, for me, a lot of my patients, like I said, they're from Black and brown communities. It's hard for them to come into the clinic. It's hard for them to get transportation. It's hard for them to take off time from work. So only having to come once every 3 weeks for an infusion, having to take pills as opposed to coming in to drop off a pump from a daily living aspect, I definitely appreciate it. I totally understand. Like if you have one bad experience, it can definitely. And if you had multiple, and I mean, the diarrhea is no joke. The hand foot is no joke. Patients definitely suffer. So that's why, again, I have switched people, but I typically start with Capox mainly because it just helps them live their regular lives. But I don't know if my colleagues have different opinions.
I had your experience. Well, not maybe that's dramatic, but I avoid capecitabine in patients who have ostomies for sure because of diarrhea. That's one. I use Folfox primarily. I do 3 months, yes, with Folfox. Yeah, for the low risk stage 3. Yeah.
Yeah, I think after IDEA, I think really the high risk population, if you're going to do 3, definitely you want to do Capox. For everyone else, I try to still do Folfox. I've definitely found it much more tolerable, and people get used to the pump pretty quickly, actually. So.
Yeah, I also don't like.
I guess I'm the only one.
And check DPYD too. Definitely.
You just have amazing skills to give both 5FU and CAPE.
There you go. Well, and I agree. So checking DYPD, you should be checking on any patient you're starting. And that's not something that I learned in fellowship because we were not doing it then. It is something that every single patient you should be checking.
I more recently finally adjusted to kind of reflect that, hopefully more encouragingly. Okay, one more. Yeah, what you got?
Sorry, if the DPYD result is delayed or you're still waiting for it and you have to delay therapy, do you still wait or do you consult the patient about, hey, this is the potential risk, do you want to start now or do you want to wait? So what's your practice?
Yeah, I mean, in our center, it usually takes about 7 to 10 days to get the result back now. So for most people, I'm usually seeing them about 4 weeks post-op, so I'm well within the window of being able to start adjuvant therapy in a timely way. So I have it drawn that day. I'm usually getting ctDNA that day as well. So if you're getting a draw anyhow, get it done right then. So, but yeah, if it's only a week or so and you're still within that 10 to 12 week window, I usually would wait still.
And sometimes if you're friends with the surgeons, because sometimes they see the patients before you do, post-op, you can ask them to draw it in their clinic. So that's another possibility, and that way it lessens the delay.
Excellent. Thank you all so much, the panel. If we can give them a round of applause. That was very edifying. We are in good hands. Yeah.
Thank you.
Thanks.
Thank you.
Thanks.